Sorry to
Okay.
interrupt.
Can you hear me?
Yes.
Okay, good. You know how I have technical difficulties. Let me just step away for 1 second, if that's okay, because I left my papers at, oh, he's bringing them. I left everything, thanks, at the copy machine. All right.
Okay. You know when you're
How's
ready,
everyone's
Member
Monday?
Coco.
So far,
Good.
it's insane here. Okay. All right, I'm ready. If you want to start.
Yes.
Thank you.
Okay, so the meeting is called to order at 3:02 p.m. And I'll do roll call. Member Coca.
Present.
Hey, Member Mesia Villa. And Member Father Raphael. We do have
Present.
quorum. Yeah, we do
Thank
have
you.
quorum. Members of the public may attend and participate in the Southern Nevada Community Health Center Finance and Audit Committee meeting by telephone. To join, dial 702-907-7151 and interim phone conference ID 318-079-111#. To provide public comment by phone, press *5 to raise your hand during the comment period. When called upon, press *6 to unmute your phone. Thank you.
Okay, next on the agenda is the Pledge of Allegiance.
Okay.
I pledge allegiance to the flag
To
of
the
the
flag
United States of America
States of
and to the
America,
republic for which
to
it
the
stands,
republic which it
one
stands,
nation,
one
under
nation,
God,
under God,
indivisible, with
indivisible,
liberty and
with
justice for
liberty
all.
and justice for all.
Amen.
Thank you. Okay, next on the agenda is the adoption of the March 16th, 2026 agenda.
Well, Member Coca,
Oh, you
first
didn't
is the
do,
first public comment.
okay, I'm sorry, I thought you did the first.
I
Okay.
just read the instructions for it, but right now online we have no one for first public comment.
Okay, great, thank you. Okay, now we'll move on to the adoption of the March 16, 2026 agenda. Can we get a motion to adopt the March 16th, 2026 agenda as presented, please?
I make a motion to adopt the March 16 agenda.
Thank you, Father. May I get a second?
It's just you and Father Raphael on.
Oh, I
So
thought
it's just you two.
Blanca's not there. Okay.
No, she's not here today.
Oh, okay. All right. In that case, if it's just the two of us, do I then just pass or
Yes.
yes?
Go ahead.
Yes.
Yeah, this is Edward Winder, sorry. Madam Chair, the board agenda can be adopted without objection. So provided you don't object, after the motion,
Okay.
you can consider it adopted.
Okay, great. I adopted. I don't have any opposition to adopting the agenda.
Yeah.
So it passes. Okay. Okay, next on the list is the consent agenda. So items for action to be considered by the Southern Nevada Community Health Center Finance and Audit Committee, which may be enacted by one motion. Any item may be discussed separately per board member request before action. Any exceptions to the consent agenda must be stated prior to approval. Father Raphael, can I get a motion to approve the consent agenda, please?
Yes, I definitely I can make the motion to approve them.
Or-
I haven't seen them. Is there any issue with that? Because I was not in the board before that or by that time.
Okay.
Is that okay?
Well, this is the consent agenda, correct? So this is just we haven't
Yes.
discussed yet the meeting minutes, but no, I apologize. August
Okay.
18th, 2025. Yes, it's been a while since we've met. So, Edward, do you have
Madam
any?
Chair?
Yes.
Madam Chair, these can be adopted without objection as well. And so
Okay.
if you can offer it to the group of two, and assuming no objections, you can announce it adopted.
Okay,
Yes.
let
approved.
me,
No
if I may,
objection.
I'm sorry, let me ask a question. So just so I'm clear, then I don't have to motion to approve since it is just the two of us. I can just go ahead and adopt, or I still have to bring it to father's attention or for
Well,
motion.
good question. Yeah, good question. For these items where there's generally anticipated to be agreement, so the consent agenda, the agenda itself, they can be approved without objection. And while traditionally we have a motion and a second and a vote, in a small group like this with two members, it can be easier just to approve without objection and move on. But you can do a motion and a second, and then effectively you've approved it.
Okay. All right. So I make a motion to approve it.
Yeah, I think we just lost her. So I think she just dropped off here. So hold on for a moment. We'll get her back here. Here
Okay.
she comes. Member Coca? Member Coca, can you hear us?
Sorry.
Okay, there you
Hello?
are. Yes, we can
Okay.
hear
Yes.
you.
You might not be able to see me. I don't have a great camera on this computer, and I was trying to adjust the volume because I can't hear you. It's not as loud as I would like. But sorry, I got out of the thing. Okay. Ed, I'm sorry, you were answering my question.
Sure, no problem. So with small groups like this, it sometimes can be easier for the consent agenda and for the agenda itself to just approve without objections. Traditionally, our boards and committees will do a motion and a second and a vote. But for these for these kind of easy items where there's not expected to be any sort of discussion, the chair can simply approve it without objection.
Okay, but I still have to motion Father Raphael.
Yeah, I can make the motion. I make the motion to approve the consent agenda as presented.
All right, thank you. All right, I believe I already motioned for Father Raphael to approve this, so I'll adopt the consent agenda as presented. I have no opposition.
Correct.
Thank you. Next on the item, report, discussion, action. First is nomination of chair of the Finance and Audit Committee. Okay. Oh, wait, I'm sorry. Yes, okay, we're on the right thing. Direct staff accordingly or take other action as deemed necessary for possible action. Okay. Is my term up as chair of the Finance and Audit Committee? If so, that's fine. Can Randy speak to?
Yeah, Jasmine, I think we just opened it up because Father is joining the committee as a new committee member. And so this is an opportunity to revisit whether or not we want to make a change in the leadership role or not.
Okay. How do we make that? How do we have that discussion?
Well, I guess I would just ask, are either of you open to assuming the role, or Jasmine, are you open to continuing on the role? It's really up to the two of you. And of course, we don't have one member with us today.
So. Okay. Father Raphael, are you interested in becoming the chair of the committee?
Well, I would say that if you are willing to continue, I would support you as support the health center all the time. So unless you don't want to continue, but if you're willing to continue, you stay there, and I support the committee.
Okay, sure. I'm willing to continue. I did want to open it up. You know, I want to be fair, and it's been a while since Father Raphael has been on our committee, so I wanted to offer you that opportunity, but I'm willing to remain in the role.
Okay, good.
If
Good.
that
Yeah,
is
just
okay.
I think that's good. You know, you just remain on, and I always here to support you, the committee, the health center, and everyone.
Okay, I appreciate that. Thank you. Okay, so it's so funny.
So I make the motion to approve that you, Ms. Coca, continue as the chair of the Finance Audit Committee.
Okay. Thank you so much, Father. And I will, I don't oppose adopting the motion to approve since we are the only two present today. A motion to approve as chair of the Finance and Audit Committee as presented.
All right.
Is that all that we have to do? Okay. Thank you. Number 2, receive and discuss the January 2026 year-to-date financial report and approve recommendations to the Southern Nevada Community Health Center Governing Board on March 17th, 2026. DJ, take it away, please. Thank you.
I think you're
DJ, I
muted.
think you're on
You're
mute.
muted, DJ.
How about now?
We can hear
Yes.
I
Okay.
can hear you now.
Okay, so I'll repeat that. So, good afternoon. For the record, DJ Whitaker, CFO for SNHD. Madam Chair, members of the board, what I'm presenting first is our financial report, results as of January 31st, 2026, our unaudited position. Next slide, please. So our summary slide, we have under the revenue side, we have our general fund revenues are at 21.64 million. That's compared to a budget, a full budget of 22.79, and that is an unfavorable variance of 1.15 million. And our grant funds and our special revenue funds, we are 2.71 million compared to a budget of 4.45 million. And that's also an unfavorable variance of 1.74 million. So in total, our revenues are at 24.34 million compared to a budget of 27.24. That is an unfavorable variance of 2.9 million. And then we will get into some of the contributors to that as well. Under the expenses, our salary, tax, and benefits, we're at 8.27 million, and that is compared to a budget of 9.68. So that is a very favorable variance of 1.41 million. And our other operating expenses were at 17.27 million compared to a budget of 118.13 million. That too is a favorable variance of 860,000. Our indirect costs and cost allocation, that is a favorable variance of 1.3 million. Again, when we have lower activity in our expenses, our indirects follow our direct expenses. So when that's lower, then of course the indirect cost allocation is going to be lower as well. So our total expenses are at 31.75 million. That's compared to a budget of 35.31, a favorable variance of 3.56. So you can see our unfavorable variance in the revenue side is offset by the favorable variance on the expense side. So our net position is at 7.41 million negative. That's compared to, we would have expected to be at a little over an $8 million deficit. And so that's actually a favorable variance of 660,000. Next slide. Okay, so here's some of the detail to support what we just went over. We are writing our accounts up. We're doing our write-offs quarterly instead of waiting until year end. So we do have through December, and we'll be doing another one in March. So it does contain half the year's write-offs in these numbers. Our wrap or true look back payments, we did have some of those that posted. So that would be in our other category. You can see that we're 671,000 ahead in that particular line item, and that's as we get those, if we close the year and then we get subsequent payment, then we record it as current year revenues. That's what's in that line item up above on the revenue. And in our adopted budget, we are, the augmented budget is in the packet today, so we're still using the original adopted budget, which does not take into account all the activity that was in the budget that we adopted a year ago. So we did have some new grant funding on the revenue and the expense side, and so neither of those occurred. So right now we do show a variance for some of that activity as well. So overall, you can see our net position. Again, it is in a better position than we would have anticipated based on the budget we adopted last year. Next slide. Just some graphical representation of where the revenue sources are, and it looks like we might have lost our header on the second one, but it's still FQHC. So pharmacy, you can see in the adopted budget, it made up 76% of the revenue, and now it's those should be the expenses on the right-hand side, with the pharmacy at 64%. So you can see, even though it's a big piece of the pie on both sides, you can see that we still have that margin coming from the pharmacy. Next slide. Okay, and then this is just a further drill down of the departments that are making the contributions in our charges for services and our other revenue with our grants. And so you can see some of this is in the pharmacy. If you will recall, in January, I think it was last month, Dr. Glee did a presentation and covered some of the activity where we have a decrease in some of our revenue. And so we are keeping an eye on that very closely. And so the 1.9 million in pharmacy, and you'll see on the next slide, we are actually have some activity in the expenses as well. So again, our grants, the Ryan White is where the activity that we record in our adopted budget, and we will be taking care of that during augmentation. Next slide. Gosh. And here you can see, so even though the revenue in pharmacy is down more than the expenses, you can see we still do have a $600,000. So right now we've not spent as much as we would have anticipated. And just as a reminder, our budget, because we take the full budget and divide by 12, so there can be timing differences that cause some of our numbers to not be quite in alignment with the percent of time that's elapsed. So again, coming down to that 35 million would have been our total expenses anticipated, and we're at 31 million, so $3.5 million variance, and that does include that large $1.3 million of cost allocation that's not represented there too. Next slide. Okay, this is just in general, we like to put in here to show our patient encounters, and you can see year over year within the areas that we in the primary and preventative care, a 46% growth overall across all of them. We were at 21,356 last year at this time, and we're at 24,592 encounters. So that is year over year a 15% growth net. Right now, we do have some movement between the categories, so you can see a shift, but overall a 15% growth year over year. Next slide. The same numbers just by facility. So we have Fremont separated, and all the other locations would fall into the main category. So again, 15% growth year over year, and interesting enough, it's 15% in each location. Next slide. Okay, this is just the descriptions. If there's anything, any activity that you're curious about, we can certainly go into the categories and the descriptions of those if you wind up having any questions on those definitions. Next slide. Next slide. And this is just further detailed by department on this slide. of the month-to-month activity. So you can see if there's any anomalies in our data. You can see in December, our pharmacy was at 2.8 million, and then January 2.5. Again, some of that can be timing, especially on the expense side as well, because sometimes we have orders right at the end of the month that they would wind up in inventory instead of being expense. So sometimes we do have timing differences, but you can see pharmacy is fairly steady. In the expenditure side, we did have 3 months where it was a little low, and then we popped up back up to what we were doing in July and August. So again, now that we have 7 months under our belts, some of this should even out some. Next slide. And then this is our report by type. So this is just in general, not departmentally, but overall our revenue, and then our salary expense types by salary, tax and benefits, travel and training. So you can see that in January, I'm fairly certain that was a month when we had 3 payrolls, or our accrual would have been more in that month. So again, you can see it does fluctuate some. And then any activity that we would bring on, vacant positions and that kind of thing can impact those averages as well. Okay, next slide. Okay. Any questions? Seems like I just threw a lot of information at you.
Well, I don't have any question. I just have to say the same thing that I did the last meeting. I'm so glad to see these reports detail, and it gives us the sense that you are in top of everything in internal control and reporting. Now I love it. I love it, and not only the reporting, the numbers that we are showing. It's we are in control. We are pretty close to the budget, which is normal, and it's not easy. And I'm so glad. I don't have any questions about any item. I think that this is a well and detailed report for any type of analysis that we would like to make.
Thank you.
I agree. Always DJ and her team they do a great job with the reports, and I know we'll discuss this more in detail tomorrow at the board meeting, but everything looks as good as it can be. Next I'll make the motion to accept can I get a motion to accept the January 2026 year-to-date financial report as presented and approve recommendations to the Southern Nevada Community Health Center Governing Board on March 17, 2026.
I make the motion to accept it.
Okay, and then
And Madam Chair, can I clarify the instructions that I gave earlier as it relates to these action items?
Yeah.
For these action items, a motion and a second would be good. And since it's just the two of you, that's good enough to approve it. If we were to have a third, then we'd want to do a vote. So we have a motion, and if there is a second, then we can consider this approved.
Okay.
I'll second it. So
Thank you.
now it's approved, right? Motion approved. Motion to accept approved. All right. Thank you. I appreciate that, Edward. Receive and discuss the augmentation to the Southern Nevada Community Health Center fiscal year 2026 budget and approve recommendations to the Southern Nevada Community Health Center Governing Board on March 17, 2026. DJ, is there? Yeah. Okay. Sorry.
Yeah, it'd be, sorry, I saw Randy's thing lit up, so I wasn't sure if he had something he was going to add. So,
Okay, no problem.
okay. So this is the augmentation. If you'll recall, we occasionally do at least one, but this year we are doing this one, and then we'll do another one in June. And so the unlawful to expend money in excess of the amount appropriated. And so we try to stay on top of where our expenditure levels are and make sure that we keep our budget aligned. So we just like to throw this in there to say that we are aware, and we're definitely with Randy and his team trying to stay on top of all the changes that are happening and make sure that we have it in our appropriation. Next slide. Okay, as a summary, so staffing for fiscal year 26 is projected to be 119.5 FTE in the augmented budget that we're presenting today compared to what we adopted last year at 126.5. And we do have an FTE chart at the end of the presentation, but that is related to the positions we've been talking about that we had we're looking for at a grant opportunity, and that did not come through. So the positions also didn't come through. So this is just us removing those activities from the budget. The general fund revenue, we're projected at 38.5 million. That is a decrease of 600,000 from the fiscal year 26 adopted budget. And if you'll recall, Dr. Bleak presented some information that we did have a change in one of our relationships related to the pharmacy, and then just other refinements to our activities in the clinic and any other revenues. And so even with we're expecting our RAP to generally be the same level, except for on January 1st, the billing for that started was a little different. And so we'll be staying on top of that as well to make sure that we don't see any big adjustments in that area. On our special revenue fund, our projected was at 5.1 million in this augmentation. That is a decrease of 2.6 million. Again, we wound up not pursuing the one grant that we had included, and then just other adjustments that may have come through as we received our awards through the year. So again, we will align this again in June, depending on how our funding comes through, and then any other expected new grants or adjustments. On the expense side, we're at 58.4 million, and that's compared to $61.3 million. So you can see we're taking revenue and expenses both out, with the special revenue coming down 3.2 million in the revenue in total between general fund and special revenue, and then this would be just around 3 million. So we're adjusting both our revenue and expenses. Next slide, please. We like to include the org chart, and no changes from our adopted. Next slide. Okay, and then here's where you can see our charges for services, seeing the going from 37.5 million to 36.9. Our transfers in usually stay about the same. And intergovernmental grants, again, that's the number we just went over, with those being reduced from the adopted to the augmented. And then other contributions, that would be where our RAP payments are, and we're still anticipating to stay around the same level. We will keep an eye on that. I think going forward, because of the methodology change and how we actually bill, that will have a little bit of an impact, because instead of being maybe in this category for our actuals, it'll shift over into the charges for services, because the way it won't be as distinct. So we'll keep on top of that and try to keep abreast of that so we can point that out too. Next slide. And then this is our activity by our budgeted revenue by department. And so you can see here where the changes actually are. So you can see some our refugee health, even though we have actually seen some activity, we did take it's below the rounding that we would have been at. And then our Ryan White, that is one of the changes where we had the personnel that were coming on, so we're changing the revenue as well here. Next slide. Okay, so our total charges for services is augmented at 36.9. That is a decrease of $600,000. And then just remember, a major component of our charges for services is the pharmacy, and that's at 35.2 million. Special revenue funds, so we did have that decrease, and primarily due to that reduction of the existing grants. Ryan White, some behavioral health year over year, we had some activity in the adopted budget that may have blended out as well as the refugee health. So, and then family planning is one I think Randy mentioned a little earlier, but we just have to keep an eye on how those come in, what level they come in, and then we'll do a second augmentation in June to make sure we're aligned everything. Next slide. On the expenditure side, we again, we're going from 61.3 million in the adopted budget to 58.4 million. You can see a portion of that is under salaries because of the personnel FTE that we're taking out, as well as that would impact taxes and benefits because we would have assumed that we would have had those costs as well. And the other areas are less impacted. Our indirects, again, they go from 12.9 in the adopted to 11.6, and that is related to reduction in other expenses. We have a reduction in indirect because it is based on our direct charges. Next slide. And then we have it by department. Again, you see the pharmacy has the biggest part of this pie, but again, our transfers outstayed the same. Behavioral health is slightly down, and then the Ryan White is the significant one again for that reduction. Next slide. So again, the total expenditures, we augment the budget at 58.4 million compared to 61.3 adopted. Our total expenses for the pharmacy are 36.7 million, and that is 64% of the entire FQHC expenses that we show. Salaries and benefits for our general fund and grants is 14.8 million. That is a decrease of the 1.8 million. And our 26 adopted budget include a full year of salaries. So in addition to removing some FTE, we would have any, if we had vacant positions for that first 6 months that elapsed, we would have taken that out of the current budget as vacancy savings, so that those two things are included in that as well. Next slide. These are just charts to show the revenue and expenses by department. This is probably the only slide where they come together. And then this is by department. Next slide. Same. And then this one, the first one included our cost allocations. This does not include those, but you can see natural before we apply the cost of administration and that to the departments what they generate for revenue and expenses. Next slide. Here we go. So staffing, you can see that we are reducing by 7. In the Ryan White, that was the removal of the eligibility workers that were on the grant. And then we did have some activity that changed between the programs for a net of reduction of 7 FTE. Next slide. Questions? We can go back to any slides that you have questions on.
I don't have questions, but I would like to make a recommendation or suggestions. Is there any way to, I don't know, I understand that maybe today we don't have it, but I would like to see the adopted budget versus the augmented, but in a regular financial statement format, that we can see numbers and columns instead of, I know I love the graph, I know the pie charts and all that, but I really love to see more for analysis and comparison the regular financial statements, that we can have 2 columns, that the budget, the adopted versus the augmented, and we can compare line by line. You understand what I'm saying?
I do.
Yes, like, when you presented the regular financial statement, for example, the January one, we can see all of them. We can see the budget versus the actual one. I would like to see the same thing, but the adopted versus the augmented, so we can see the variations and where the changes and the augmentations and reductions are. Okay.
Yes.
This is Randy, excuse me. DJ, would it be possible to provide that type of presentation for the second budget augmentation?
Oh, absolutely. Yeah. I've written it
Would
down.
that be
Maybe not
okay?
by tomorrow, but
Yeah, not by tomorrow. So is that acceptable, Father, for the second augmentation, which I think, is that delivered in June, DJ?
Yes,
it is.
that's fine. You know, it's just a suggestion because for the analysis purposes, it's easier. You know, we can go for with the charts, the bars, the all the graphs, and we can understand that. But definitely for analysis purposes, it's that definitely better to have the regular financial statements and columns, and we can see them easier.
Yeah, no, makes good sense.
I appreciate the recommendations, Father Raphael and Randy and DJ, and considering those recommendations. So we'll look forward to seeing those charts in the future. Can I get a motion to accept the fiscal year 2026 budget augmentation as presented and approve recommendations to the Southern Nevada Community Health Center Governing Board on March 17, 2026?
Yeah, I make the motion.
Okay, I'll second the motion. Adopt it. So passes. All right. Thank you. Next, receive and discuss potential finance reports and approve recommendations to the Southern Nevada Community Health Center Governing Board on March 17, 2026. Okay. Thank you.
Randy, you lit up again. Did you want to lead with something or did you want me to?
Sorry, DJ, I'm not sure why my guy's going off, but no, take it away, please. Thank you.
Okay. Okay, this is in response, I think, Father Raphael, to your request for some additional information related to our billing department. So I don't know if you can see her, but Donna Buss is here with me. She's our revenue cycle manager. So she leads this team and has implemented most of what you see in the presentation. So in an effort, I think, to make sure that we get the information that you're looking for, and maybe other board members, we went through just to go over an overview. So our revenue cycle medical billing for SNHD was brought in-house in fiscal year 22. So I think it was late calendar year 21 or fall, I think. Our prior medical billing was performed by external third-party companies. So our some of what we didn't have with that relationship was our qualifying encounters for prospective payment system. We always call it PPS, and I forget to define it for people, but our RAP payments were not submitted because we just actually received our, I don't want to call it final rate, but the current rate. We're no longer on the original temporary one. And then denials, rejections, and receivable balance were not resolved consistently, and our systematic issues were not consistently identified and resolved. So part of this is our understanding of previous discussions and concerns identified prior to Randy, myself, and Donna. All of this Donna came in right as they were implementing in-house. And then, of course, Randy and I came after that. So a lot of it is based on our understanding of how things were working. And so we just want to put that qualifier out there. This is based on our understanding. So,
Correct.
Yeah, so next slide. Okay, so we just wanted to bring up the state Medicaid establishes interim and final rates for prospective payment system for qualifying encounters provided for the FQHCs. Medicaid managed care organizations may pay less than the PPS rate for the FQHCs, and then the RAP payments are designed to cover that gap. So as I mentioned earlier, we did go to a different way of billing this January 1st. Not necessarily by our choice, but that's the current status for that. So that would be the billing team identifying the qualifying encounters and then submitting that to make sure we got our, get our payments for that gap. Beginning in calendar year 26, the MCOs are providing that full PPS rate, and that's, I think some of the systems we're still working through all of that. So instead of having to do two processes where we bill, get that payment and then submit for the gap coverage, what we're supposed to be seeing now is we should be getting that entire payment from the MCO. So that's part of what Donna's doing. She's working with them to make sure that's coming through. It just started in January, so we do have, I think we've identified some problems working through those to make sure that everything comes through and we don't have any revenue loss. And related to that, I would say that we have, it will change a little bit in our budget. We're going to have to determine how to figure that out, because right now, when we get that gap payment from we post it and it shows up in a line item by itself under other. So now when they're making these payments, it's actually related, directly related to the claim. And so it'll switch a little bit. It'll go probably from the other revenue into the actual charges for services. We weren't able to do that before because it wasn't really directly related to the claim. So what our expectation would be, though, is our total revenue won't change. It'll just be the category it comes through because of the process that next slide. So for our billing team, our successes are our RAP payments increased from 0 because we didn't have this in place before Donna took on the challenge with Randy and the crew, and I think we had a couple times getting our rates in effect. We had the interim rate, but so our final PPS rate was determined in 2025, but we have collected over $3.8 million in those additional payments. The largest aging category has shifted from over 180 days to 0 to 30 days. We have a couple charts in here as well. The billing department, they actively work denials, rejections, and any other issues with the clearinghouse, and they submit reprocessing in a timely manner. So we do get our month-end reports, our payment processing, and so they are pretty quick to be able to identify activity that might be rejected or getting denials for any particular reason, and work on those with the payers. Donna works with the provider relations representatives from each payer to correct claims processing issues, pursue contract amendments and reimbursement fee updates. We do a monthly review meeting with revenue cycle manager and the operations and business teams in place to optimize the revenue cycle. So anything that cross-divisional piece of it we have in place as well. And then they implemented patient statements to recover additional revenue for activity not collected at time of service. And then we just we send out a couple, and then of course we have our write-off process, which I mentioned earlier on our revenue side. So we pull the numbers from this activity for that greater than 12-month activity to do our write-offs. Next slide. And this is just to show the $3.8 million, the years it was received. So fiscal year 23 was the first year, and then it has grown. And then we put the fiscal year 26 one in yellow because with the change in the way that the RAP payments are recovered, that may not show up in that bucket for January forward, but we should be able to see it in our total revenue. Next slide. And then the aging reports we used from our ECW. This is our total medical AR. So this is SNHT as a whole, not just the FQHC. So you can see that we in 22 we started at 1.5 million. And the variation was 64% of that was in the greater than 180 days. And so now in the fiscal year 26, February year-to-date activity, that grouping is at 32%. So you can see we have a better.
This is Randy.
Mhm.
Sorry to cut you off there. Yeah, definitely. And we've cut it in half. So great job to Donna and the team. How does the uninsured sliding fee impact that bucket? I would presume that there's charges for sliding fees and outstanding payments. Is that activity is living in these charts, correct?
In this one, if we go to the next one. This is the
Thank you.
Yeah, so you can see that, and I think in fiscal year 22, Randy, correct me if I'm wrong, but I think we were still at an 18-month write-off. And so in 22, we were still probably trying to work with what we had outstanding on our third-party billing activities. So, but yeah, so it's the 23% is not with our self-pay. And that would include and 26, that would include a 12-month write-off period, not the 18 months we used to be. Right. And then a couple of things in the last two buckets. We did have some activity with a system configuration. I think they started a new system, and when they did the configuration, SNHD's FQHC designation wasn't captured. And so we've had I want to say it's maybe over a year, going back and forth to make sure that they got us reinstated for that. And then then we had to resubmit some activity to make sure that we got the collection on that. So some of it is definitely they're keeping track of what's being denied, and then finding the root cause for it and making sure that we move forward and work with the payers to make sure that we get it corrected and then go back and get our funds from the prior years if it crosses over. And I do have, Donna is here if there's any specific questions related to the billing or what she's seen, if anybody has a question. And then really just to get, I guess, Randy, at this point, what type of reporting going forward would you like to see, or was this just a request for an update?
Absolutely. Well, Father,
Yes.
let's let you, any questions you may have, and then we can move into that conversation too.
Yes, first of all, thank you again for working on this and presenting those numbers. It's important that we understand that how important it is to keep an eye on the receivables, because maybe even in any kind of business or entity or clinic, we can sell, we can provide service. But if we at the end do not collect the service, we are gonna end it up in writing off and losing that service. So in this particular entity and our health center, it's about the same. We understand that we have self-pay people that they are uninsured and the insured. And we can see the achievement and the improvement when we brought the billing to in-house. Now, it's important to, and I have some questions that for the self-pay, we have a sliding scale, and we understand that some of them cannot pay the 100% of the service cost, and then we're going to have to work on the collection with them, right?
Correct.
That's correct.
All right. Now, what about the insured? What's going on? Why we still have receivables, and maybe what is the main issue with the insured having the billing in-house? Why we are not getting about 100% of those insured claims collected? What is the main issue?
We do have one issue with a payer, like DJ said, with the system configuration that they had. So that made our over 180 day go pretty high. They are currently reprocessing all of our claims back to November of 2024. And so we are now seeing payments come in. So that was pretty high, pretty much 2 months ago, which is now coming down. And in the process of it, we're still watching that. When they tell me they're finished reprocessing, then we will continue to look at those and go back with what we found that did not process and pay. So that's where we're at with those. So we do see some trends that come over that we're on top of, and we're watching with, you know, all the payers across the board to make sure we do get our revenue for that. And they could be a lot of different denials for it, but we're watching all the trends.
Yes, and then that's definitely, you know, I would say that that's one of the main issues that we have to focus on, and what's going on, what the denials, what is the billing issues, maybe the code, and what's going on with the billing that we do not end and collecting the money, because we understand how hard it is to, you know, collect the money with the self-pay. You know, once they don't respond, they don't. We understand that,
Yeah.
but with the insurance and having the billing in-house, this number should be, well, the minimum, because we need to know, identify what the issue is, and try to reduce these issues and try to collect 100% of it.
Right. And in my experience and in the billing world and accounts receivable, 80% of your claims will go in clean and 20% will deny. They could deny for all kinds of different reasons, and there's nothing wrong with the claim. So the insurance and the payers kind of hope that people don't do their AR and look at their aging, whereas we do. And that's really, besides sending the claims out, that's our biggest priority, is working those claims. Because if nobody looks at that, then that's, you know, free money basically for the insurance companies.
Correct.
So, yeah, so that's definitely one of my highest priorities is the AR.
Yeah,
All right.
I think right now for January with the change to shadow billing, it has caused some, right? Because we're trying to implement, they're trying to implement. So I don't know that it's going to be big because they are on top of it, but it may be a little bit of a gap while we get all of that aligned and make sure that we're getting all the payments, because when it denies, it's denying what they would have paid before this shadow billing went into place, as well as the wrap. So we just have to, Donna staying on top of that part to make sure that they get their system set up and we get our payments.
Perfect. Yes, thank you.
And Father, on the provider side, Dr. Carter continues to work with our providers on, you know, the documentation and the correct coding. We recently brought in an outside vendor to do some additional training to support that. And then the health center management team also has a standing revenue cycle meeting with Donna, where we're looking at things that might even be occurring at the front office, just to make sure that that part of the revenue cycle is being addressed as well.
Excellent.
Good. So I think, Father, part of what we wanted to inquire with you, and Jasmine, please use it as well, is this report that you just saw here today, is this something that you would like to see on a reoccurring basis as part of our monthly report?
Yes, definitely. And remember, it's not that I want to see them. It's for all, you know, especially for the health
Absolutely.
center, that we can see that we are in the board. We always, of course, we praise for all the good job and all of that, but our main function is to identify potential areas that we need to improve, you know. And then this is one of the things that I always ask, you know, and check. And besides, you know, we are having a great finance reporting and controls, but I think that definitely billing and accounts receivables are very important. So I would like to see them all the time.
Good. Okay. And you, the format that it was shared, those the bar graphs, you were good with how that was being shared, or is there more information?
They are not my favorites. Yeah, I like to see
Okay.
that.
Well, is that something, and maybe we could work offline even with some various kind of formats and see what,
Yeah,
you
for
know,
me are
might be
more,
the best.
as a CPA, I like to see more the columns and try to compare, the billing and aging and try to see exactly, but in numbers and columns instead of graphs.
Okay. What about this thought too? Sorry, Don and DJ, we didn't talk about this ahead of time, but is it conceivable to see this level of activity at the individual payer level? Are we able to break that out if we've got one particular payer or class of payers that we're seeing something different? Is the data able to be shared that way?
We can look at the dashboards that we recently produced. I mean, yeah, the data lives, right? So we can probably combine that. We can check with Justin for sure and make sure that we can.
Okay.
Yes, and
Okay.
what you said, Randy, I think it's very important, and I'm pretty sure that Donna knows that she is in billing as well, and we can identify when we see providers, maybe there is a two or three or main providers that we are having more issues with. So when we see the receivables per provider, maybe we'll say, well, there's an issue in this system that they are denying or we are not processing or we're not collecting for this specific provider, and maybe it's the main provider who is causing all of this. So it's good. Every report that we can see in detail is going to give us more information in order to fix the problem.
Agree. Okay. So it sounds as though the team may need some time to kind of work through this. We might have a couple of iterations to kind of go through to figure out what we can produce. I'm always trying to be sensitive to the DJ's team. They got a lot on their plate, and some of these I think might have some manual processes to them. But let's come up with some drafts and see if we can find what works the best.
Yes, and we understand. It's always it's a work in progress. Maybe it's not for tomorrow, for next month, but as long as we're working on it,
Yeah.
we can see the progress, and maybe by the end of the year, we can see, oh, when we started maybe paying more attention or working on this, we have improved. That's how it is.
Sure.
Yep.
No, makes good sense. Other than the AR report, the aging report, was there anything else that was top of mind for either of you about things that you would want to see on a reoccurring basis?
No, no, I'm okay. That's the only one question that I had as of today.
Okay.
Can I,
So
I'll
the
just
only other thing,
say,
yeah, go ahead,
oh, sorry.
Jasmine.
Well, who was Father Raphael? Were you finishing your comment? Well, I was just gonna add, I think if we can try to get what Father Raphael is requesting, I think, whatever is best for this committee to be able to, I guess, provide more input and even more support to the finance team at the health center, then we should try to do that. But I do agree, and it seems like Father Raphael is on board. If we can maybe have a timeline for that in the future, because as we indicated, maybe DJ and her team, they can't do it by the next meeting or even the meeting after that. So, because I agree. I mean, I understand Randy too, and DJ, you guys have a lot on your, I do agree you have a lot on your plate. But I think we can come to a, not a consensus, not necessarily, but figure out a way to do all of this, but within a timeline. So offline, maybe we can talk more about that. And I was also thinking, and I think Randy, you're going to say something about tomorrow. Is this something that we would need to bring up to the board in terms of what they may want to see when we report on the, when we do this part?
Absolutely. No, thank you. Two thoughts. Let me take the first one first. the health center's leadership team has identified one other report. We've been in conversation with DJ and her team, and that's the payer mix report. Right, we've talked a lot around the imbalance of our payer mix. We've got some high-level draft reports that we've created, and I think that might help to round out our understanding of what's happening within our payers. So I'd like to just put that out there. We could definitely come back, I think, at our next finance committee meeting next month, maybe with kind of a timeline of some of these, bringing on some of these reports, and then, being able to produce some drafts and get some agreement that the reports that we're presenting are the ones that we want. So I guess I'll turn it over to you guys, because the health center leadership team is going to run with the payer mix regardless, but want to make sure, Father Jasmine, is that something that you would be interested in seeing as well?
Yes.
Yes.
Right. I believe so. Yes.
Yes.
Okay.
And it's good, to bring it up tomorrow and the board meeting and say, hey, and we are all we're working on this, and we expect for this specific deadline to have more details, and we're working and identifying this issue in order to improve the accounts receivable, blah blah blah. So it's good to bring them up tomorrow.
Okay. And we do have an agenda item to do just that. So, DJ will share this presentation, and then we can move into some dialogue, and we'll look to the two of you to share what we've discussed here today. Donna, our board chair, and I have had a couple of conversations as of late with regards to the governing board meeting, and wanting to be good stewards of our time, and really presenting the most relevant and on-point data. One thing that we've talked about actually was really leveraging the finance committee further to really do this deep dive like we're doing today, and at the full board meeting, getting up at a higher level. And one thing that she and I spoke about was perhaps having DJ just present her very first page of the monthly finances at the board meeting, which is that summary page, right? The summary of the revenue and expenses that shows the final net position. And then also sharing the utilization, right? This is the utilization by service line, as well as the utilization at the site level, and have that be the finance presentation at the board. Of course, here at the finance committee, we can go through the full deck like we've done today, and then bring in any other the reports that we're talking about here as well. The thought of doing that would be twofold. One is to make sure that the finance committee really is operating at the deeper level, and then having those more in-depth conversations around what's happening. Because the full finance packet is delivered to the full board ahead of the meeting, of course, all the board members have opportunity to review and raise any questions. But then, in order to really help us just to stay on time with that meeting, and allow time for questions, to kind of have a higher level finance presentation using the slides that I just discussed. Wanted to get your thoughts on whether or not the two of you think that that might be a viable way to move forward with the finance portion of our monthly board meetings.
Okay.
Are you comfortable with?
Member Coca, you're on mute.
Sorry. Okay. I was saying, I mean, that's fine. I think that that's a good recommendation. I would want to have a conversation with Donna as the chair, because if we're only presenting the first page of the financial reports, then, like you said, so the finance committee were tasked with really reviewing and resolving and discussing any issues, more so than ever. How would the board chair, I guess, how will we get that information to her, so that she has at least more information after we have these meetings? I don't know if that's clear what I mean, but
yeah. I believe I'm tracking, Jasmine. I mean, and I think that would become more of the intent then of this agenda item at the governing board meeting, right? If there's anything of significance anything that we're tracking that we're concerned about. If there's new reports that we're bringing online, those could be the opportunities for further conversation at the board meeting. And of course, with the expectation, and she and I were talking about that, board members have reviewed information ahead of time. You know, when you think back to DJ's monthly report, that summary page is just that. It's a summary. Then a lot of the pages behind it is summarizing the information, just using pie graphs and different ways of sharing the information. Everyone would still have access to. It's just we would try to tighten up the meeting and provide that level of detail there, and then open up to questions. And then if there's anything of significance, that'd be the opportunity for you or father to be able to bring up, say, hey, we're looking at the AR aging report. You know, this is something that we think is important, and be on the lookout when the new report is ready. We're going to share it at the full board meeting, make sure everybody understands, and kind of approach it that way. That way we're not having the same meeting twice. And I think that's kind of where Don and I have been. Historically, you know, we have a committee meeting and then we present the exact same information back to the full board. And I don't think that's really getting to the intent of how we want the committees to work. And so Don and I were thinking that the finance committee is a great place to get this started, because historically it's been the most robust of our committees. And I think I just offer to say probably the only caveat to that is if we can't get quorum for the committee, then, you know, we can do the deeper dive at the full board meeting to make sure everyone had that opportunity to get that information at that level.
Okay, thank you. I mean, I'm fine with that. Father, what do you think?
Yeah. Oh, I'm fine too. I agree.
Awesome. Okay, so then this would be part of the discussion that we have for this agenda item tomorrow. And
Okay.
of course, I'll help to kind of lead the conversation with the two of yours help.
Good.
Okay, great.
Thank you, guys.
Thank you.
Right.
Well, I think we can go on to making the motion to accept the potential finance reports as presented and approve recommendations to the Southern Nevada Community Health Center Governing Board on March 17, 2026.
I make the motion.
Okay, I'll second the motion. It's accepted. All right. I think next is the second public comment.
Okay, and Chair Coca, I don't see anyone online for a second public comment.
Okay, thank you. So based on that, this meeting is adjourned at 4:08 p.m. on Monday. I'll see everyone tomorrow.
Thank you.
Father.
Thank you.
Thank you.
Thank you,
Thanks,
everyone.
I'll see you.
Good night.
All right, take care.
Bye.
Bye-bye.